Welcome. I'm Dr. Ostfeld, Director of Preventive Cardiology here at Montefiore Einstein, and it is our honor to introduce Dr. Joseph Margarefte. He received his medical degree from Isfahan University of Medical Sciences in Isfahan, Iran. He performed his residency in pediatrics at the Children's Hospital at Maimonides Medical Center and his pediatric cardiology fellowship at the Children's Hospital at Montefiore. Previously, he built the pediatric preventive cardiology programs at the Children's Hospital at Montefiore, and currently, he is the director of preventive cardiology at the Mount Sinai Kravis Children's Heart Center. And in addition to the management of genetic dyslipidemias, he is an expert in using quantitative echocardiography to assess the effect of chronic problems such as hypertension, diabetes, and obesity on pediatric cardiovascular disease. So he is the perfect person to be discussing this topic. Pediatric hyperlipidemia, is there evidence for screening and treatment? Thank you so much for joining us.
Thank you, Rob. Thank you for having me. I just mentioned, Montefiore is the home, and coming back, it's always an honor, and I'm feeling honored to be a part of Monty Heart Talks now. As I mentioned, I am going to try to address the issue of, is the screening for pediatric hyperlipidemia is indicated? Do we have evidence? We don't have evidence. And what is the current evidence that we have? And this is based on a discussion that we just recently had with colleagues, and a lot of news that's coming out as the results of a new recommendation of insufficient evidence for pediatric lipid screening in USPSTF. So I'm going to go over some of the data and see what can be done for that. I am going to start with this defining what is familial hypercholesterolemia, which I believe for the audience today, we're going to be short and quick on that. Current evidence for the treatment of children with familial hypercholesterolemia, and where do we are with the diagnosis rate and for familial hypercholesterolemia, and what is our evidence for universal pediatric cholesterol screening. So briefly, familial hypercholesterolemia is the most common monogenic disorder that causes early heart disease. The incidence is, depending on the studies, anywhere between 1 in 200 to 1 in 500. The largest meta-analysis shows about 1 in 300 around the world. It's an autosomal dominant in most cases, and it's a mutation in LDL receptor proteins and PCSK9 and ApoB. Unfortunately, untreated FH lead to early heart disease, and that's, I don't need to tell my adult colleague about that. 1/3 of women with familial hypercholesterolemia by the age of 60 and half of men by the age of 50 will develop clinical heart disease. This will translate in somewhere around 10 to 20 times increased risk of ASCVD in this population. Some studies even mention higher risk. Now, unfortunately, 80 to 90% of patients with familial hypercholesterolemia are diagnosed at the time of their first cardiovascular event. And of the patients that they were diagnosed earlier, 50% of them are not adequately treated. So it's a big problem that we're dealing with, that we have a big opportunity that we can help patients early on and treat, but unfortunately, only 10 to 20% they may get what they need to get for the treatment. Now, as the topic of obesity is a very common topic nowadays in risk of cardiovascular disease, I added this to mention that as the rate of obesity goes up, there are going to be patients with familial hypercholesterolemia that they're also obese also, which is a double whammy, and it's a bigger problem. Globally, 52% of adults and 27% of children with familial hypercholesterolemia are overweight and obese. And obesity, unfortunately, delayed this diagnosis by about 9 years. And as I mentioned, obesity add additional risk factors with other comorbidities that come with it. Now, in children, what do we use for diagnostic criteria for familial hypercholesterolemia? It's essentially the same as adult, but it's a higher gain. I'm going to go through some of those studies. But make it simple for my residents. I often tell them that if you have a LDL of more than 190 in a child with no family history and you rule out secondary causes of hyperlipidemia, you can be sure that this is familial hypercholesterolemia, and more than 160 in the context of positive family history. And nowadays, there is a lot of apps and calculators online that can be used. This one is from FH Foundation that they have a diagnostic criteria that you can add the cholesterol numbers and the family history and physical exam, and it will give the output as, is this a likely FH, probable FH, or definite FH, depending on what data we have there. So why is the diagnosis of familial hypercholesterolemia important during childhood? I believe that this diagnosis early on will improve outcome, and I'm going to try some of the data to support that belief, and that means improving life expectancy. This was a modeling study done to assess what is the risk of familial hypercholesterolemia. They modeled it the same way that we model how many pack year of smoking cause cancer and heart disease, with the cumulative LDL burden, and where do we get to the threshold of coronary heart disease in patients. In general population, that threshold is reached by around 55 years on average. And as you see here, there are factors that decrease that age and they get it earlier, and there are factors like female sex that they start to get to that burden of the LDL for the threshold of coronary artery disease later on. But for the simplicity, let's keep that at 55 years of age. Now, if a child has homozygous FH, we reach that threshold around 12 years of age. If we have heterozygous FH, we reach that threshold around 35 years of age. Now, if I start treatment with a high-intensity statin at 20 years of age, we can extend that from 35 to 48, but we still lost 7 years comparing to the general population. If we start low-dose statin at 10 years of age, this curve is bent much better, and we get closer there at 53 years of age. With this modeling trying to say that the earlier treatment, it may need less medication with better outcome in long term. Now, this is the main study that all of us in pediatric lipid we quote on, and we are happy that we're able to present it as a better evidence for the treatment. There was a trial of the statins which were done years ago, and this is 20 years follow-up of those patients that they were enrolled in that trial. They matched the children that they enrolled in the trial with their parents at the same age. And when you compare the cardiovascular events, this is the parents by the age of 39. We have 73% of them are without cardiovascular event. And in children that they started early by the age of 40, they were 99.3% of them, they were free of any event. And this is mortality. We have 7% mortality by the age of 40 in this patient population, in the parents, and in the children, we didn't have any mortality, 0%. I do think that in the current era, with having this data and having so much data about the benefit of treatment, this is as much as of a solid evidence we're going to be able to get, because it's going to be unethical to diagnose the patients with familial hypercholesterolemia and don't treat them for 20 years and see what happens comparing to patients that they were treated. So diagnosis of FH in children improve life expectancy, and there is a bigger benefit from my standpoint that when I see these children diagnosed, I always find parents that they never been diagnosed and treated, and sometimes we get the grandparents that they never been treated or never been diagnosed before to be diagnosed after that. In fact, we have a very close relationship with my colleagues in adult preventive cardiology, and we constantly having parents of my patients to go to adult prevention and children of their patients coming to my program. So far the key point is in children fasting LDL level more than 190 is a fetch until proven otherwise. Familial hypercholesterolemia treatment improve life expectancy by about 20 to 30 years. Diet and lifestyle modification is not enough for treatment of familial hypercholesterolemia, but they do improve other risk factors. And in the current era, with so much of obesity, diabetes, and other comorbidities associated with it, it's a very important part that we cannot ignore. Familial hypercholesterolemia is not related to obesity, but as the incidence of obesity increasing, there are children and adults with a FIDGE that they're also obese also, and we should try not to blame the obesity for every one of these abnormality and ignore the fact that the patient may have genetic disorder. So where we are with the diagnosis, I mentioned about 10 to 20% of the patient diagnosed before their first heart attack. How do we going to be able to improve this is the main topic of my talk today. There are a lot of these papers, studies done about this topic of improving the diagnosis rate of familial hypercholesterolemia. And the question always comes that we start with cascade screening, we do reverse cascade, as I just mentioned, that I do in my clinic for the parents. Should we do selective and opportunistic screening or universal screening? And then added to this complexity of all these screening methodologies, there is a question of should we do genetic screening versus lipid panel screening? It comes to mind, and it is something that it will be the future that we have to make a decision that should we move toward genetic screening or not. So I'm going to go through this history of this screening. In 1994, there was a governmental funded program in Netherlands that they started by an index case and do cascade screening from the index case, which was genetically confirmed. And they went to the first degree, second degree, third degree relative of these patients from 6 years and older and trying to make the diagnosis. They improved the diagnosis rate of familial hypercholesterolemia in Netherlands by 53%. It got to 53% of the patients they were diagnosed. That it's as good as probably the best place so far that we were able to reach the best diagnosis rate. And there was studies looking at the financial aspect of that, published already on different papers, and it's about $10,000 per quality adjusted life year gain, or reverse on investment is $9 for every dollar that they invested. Unfortunately, in 2014, those funding was ended, and the diagnosis rate in Netherlands went down significantly since 2014 in the last 10, 11 years. Selective screening, it's something that we in United States, we started in 1998, and the guideline would say that screen children from 2 to 10 years of age, if they have a parents with total cholesterol more than 240, parents with premature cardiovascular disease, if you have an unknown family history, or if there are other risk factors like overweight, hypertension, smoking, and diabetes with the child. Around the same time, when this guideline came up, there was a lot of studies happening saying that these guidelines are good enough to make the diagnosis of familial hypercholesterolemia or not. This is a large study, 20,000 fifth grade children in the cardiac project in Virginia. They were undergoing screening for cardiovascular risk factors. And they went retrospectively and looked seeing that 71% of the patients, they met the screening guideline to have screening. And out of those, only 170 of them, they had LDL level more than 160. But for the patients that they didn't meet the criteria of selective screening, 98 of them, or 17% of them, they had the LDL level more than 160. So in other way, if we put our target that we want to find patients that they have an LDL more than 160, 1/3 of the patients, they would be missed if we just do selective screening with family history and risk factors. Same cohort, there was a secondary study done in siblings that they were enrolled in that school. They were from 12,000 siblings from 5,700 families with lipid panel, blood pressure, and anthropometric data. LDL level correlate threefold more strongly to sibling LDL than the child's own BMI, highlighting the fact that probably about 70–80% of LDL level in children is genetically defined, and it's not dependent on their diet and lifestyle that they have. And same numbers as the other bigger study, about 1/2 of the patients that they were not screened with selective screening, they would have been missed because they had a negative family history. Now, universal screening started a while ago in other countries also. But in Slovenia, they had a two-step approach for universal screening. They did a universal hypercholesterolemia screening in preschool children at 5 years of age at their program visit in their primary care doctor. And only they measured total cholesterol there. And if their total cholesterol at that age of 5 years of age, it was more than 210, they were referred for the secondary tertiary level evaluation. And then later on, they added a reverse cascade for these children to find their parents. And interestingly, by that cutoff of 210, which sounds to be a low number for genetic dyslipidemia in the field, more than 90% of identified cases, they had a genetic mutation for familial hypercholesterolemia. In 2016, Dr. Wald in UK came up with a new other study and said that let's use newborn screening time to measure cholesterol level and LDL level and see how that's going to work. And then they changed that, and because of the resistance in the pediatric community, to 1 to 2 years of age during their routine immunization for the total cholesterol to be checked. And if a patient's total cholesterol was more than 95th percentile for the population that they were studying, they started to do genetic testing and do further investigation. So with this approach, for every 1,000 children that they were screened, they identified 4 children, that it's 1 in 250. Essentially, you diagnosed all of the FH patient, and in addition, they found 4 parents with familial hypercholesterolemia, which is double gain that they had in this study. Australia repeated that same study, and 448 children, they were screened. They found 32 child, 7% of the children, they had LDL level, they had a total cholesterol level more than 205. And the diagnosis of FH was confirmed in 3 of those 32 patients, when reverse cascade screening found another 5 patients. So it's not as good as the one that was done in UK, perhaps, but still we found 8 patients with looking in 448 patients for screening. Czech Republic previously had a selective screening, and they published a report that selective screening only finds 17% of FH patients in the population. Then they moved to a pilot of universal screening with cord blood by genetic testing, and match that with the cholesterol level of more than 85th percentile, and the result still is pending to be published. Now, it's not just a matter of screening, who, when to do the screening, and what level should we pick for the cutoff to make this diagnosis. As I mentioned in the first part of my talk, we use 160 and 190 depending on do we have family history or we don't have any family history according to our 2010 NHLBI and AAP guidelines. But this study was published recently, and they looked at LDL 95th percentile of enhanced population of children less than 18. And interestingly, if you look at different enhanced cohort, the 95th percentile of children 9 to 11 is 144, which is correspond to the 95th percentile of 60 years old, 50 to 60 years old of 190. So if in adults we're calling 190 a severe hypercholesterolemia, LDL level of more than 190 a severely elevated LDL, and it triggers investigation for familial hypercholesterolemia, they propose that perhaps we should start doing that from 144 instead of 160 or 190 in children. And based on this study, looking at the sensitivity and specificity, the specificity was 95 to 99%, depending on if you use 144 versus 190. And the positive predictive value went down significantly if you're using that lower number. It was 16% versus 62% if you use 190 in children. But the negative predictive value was great, and it's essentially the same. Whatever number, whichever one of these you want to use that. So if your LDL level was lower than 144, you can be assured that this patient doesn't have familial hypercholesterolemia. There is still the chance of multifactorial or polygenic dyslipidemia, but they don't have what we are concerned about as a high-risk condition of familial hypercholesterolemia. And what age is the best time of screening? This is the study that I was mentioning that Dr. Wald in England did, and looked at the detection rate and the false positive rate if you're looking at the total cholesterol and LDL level, depending on what age you are screening. Newborns are this dark blue line. Total cholesterol is less helpful than LDL, but you get to about 80% detection rate with a very small false positive rate. But the best age in these graphs is 1 to 9 years of age. And it's so separate from every other adult age group that we are looking. And implying that if we want to improve our screening rate and improve that 10 to 20% diagnosis, this is the best place to start, to do screening from 1 to 9 years of age. Because if you're looking at the over 40 years of age and you're trying to do it, you only have a 20% detection rate. That's where we are. But if you get to the 1 to 9 years of age, you get closer to 90% detection rate with a very low false positive rate. So screening age still is a matter of debate. The treatment age in general, we have an agreement around the board that we start between 8 to 10 years of age, depending on how severe is the phenotype is. But the screening age, it depends that where you're living. In England, and these guidelines recommend anytime between 0 to 10 to screen. Slovenia and Netherlands, they screen at 5 years of age. European Commission says anytime before puberty, it's appropriate to screen. And in US, our guideline recommend 9 to 11 years of age, which I'm going to get into it in a second. Now, I mentioned that should we screen lipid panel or do genetic testing? And it's an important thing if there is availability of genetic testing at some point, and as it gets cheaper and cheaper and easier to do gene testing, there are benefits to know the genes of the patient irrespective of what is their phenotype is. Even in patients with normal LDL level in childhood, LDL of less than 130 or very mildly elevated LDL, the risk of the gene positive versus gene negative patients was twice higher. And as you go up to 220 LDL, the risk is significantly different if you have a gene positive versus gene negative. So it improved the prognostication of the patient, confirm the diagnosis. It helps our cascade screening because if you have a gene, you can easily do the gene on the same gene for the family member much cheaper. The studies has shown that if you know that if the patient knows that they have a genetic problem, they have better compliance, and in fact, it improve their guilt feeling for the patients. Now, there is a question about increasing the guilt feeling for their children, which is a matter of debate, and few studies are being done, which didn't show any harm, but it's a matter of addressing it correctly that the parents, they don't feel guilt with it. Now, UK is contemplating doing genetic screening on the newborn sample in the newborn screening, and their reasoning behind it is that if we believe that this 4 pillar is correct about the diagnosis of FH, we should do the genetic screening for the patients all at the newborn age. The 4 pillar are this. Is there a strong evidence that this genetic variant caused this condition and can be reliably detected? Yes, we know that that's true. High proportion of individuals who have the genetic variant would be expected to have symptoms. Yes, I have only 1 out of 500-600 patients that I'm following with familial hypercholesterolemia that they had a whole genome sequencing for a different reason, and they had a FET gene and they don't have cholesterol problem, that one patient. But most patients that they have a gene, they have a phenotype, and that's an important thing. Now, there may need to be more testing done to see that what is the genotype positive, phenotype negative rate with this diagnosis. As far as I know, that the studies on that are very limited. Early and pre-symptomatic intervention has been shown to lead in substantial improvement in outcome in children. I believe yes, but we need more data to confirm this part of this question that they have. And is this condition that screen, it's the intervention can be applied equitably and accessible for all? That answer is yes, because the intervention in most of the time is statin, which is now available everywhere around the world. So as I mentioned, American Academy of Pediatric and NHLBI have a guideline in 2010 that they recommended universal pediatric cholesterol screening. And they recommend at 9 to 11 years of age to screen children for familial hypercholesterolemia. What's the advantage? As I mentioned, we believe that if you do it at that age, you improve identification. If you do universal, you decrease disparity. We all know that more disadvantaged people, they may not have appropriate information about their family history to come in saying that my father LDL level is total cholesterol level is more than 240. And it's improved reverse cascade screening because you're not dependent on the parents' family history of high cholesterol or early heart disease to decide about their screening. Now, a few statistics with that. It's 3% of children in the studies have LDL more than 160. So we're not looking at, oh my God, if you screen, you're going to have all these positive patients that now what we're going to do with it. There is, in fact, I'm showing some data from one of my practices that it's even less than 3%. But on average, about 3% of children, they have LDL more than 160. And if you do genetic evaluation for those patients, about 50% of them, they have genetic mutation for FH. More than 80% of children with LDL more than 190, they have FH mutation. And that is in contrast to if we do the same study in adults with LDL more than 190, only 5% of the adult, they will have positive genetic mutation. So I think that this improved gain that we have in childhood is a great opportunity that we improve the diagnosis rate for familial hypercholesterolemia. I just copied the guideline recommendation to be complete. The first to 2 years, we do not recommend any lipid screening. Between 2 to 8, we do selective screening depending on risk factors and if there is a family history. And the risk factors are as that in pediatric we're using is for high risk factors is diabetes, chronic kidney disease, transplant patients, and Kawasaki disease with current aneurysm. And moderate risk is the chronic inflammatory problem, Kawasaki with regressed aneurysm, HIV patients, and nephrotic syndrome patients. Universal screening is recommended 9 to 11, and in fact, they recommend non-fasting lipid panel that it's easier to be done any time of the day, and using non-HDL level of more than 145 and HDL of less than 40 to trigger further screening. You will get a small number of patients that they need to have further screening and having fasting lipid panel. And then between 12 to 16, we don't do routine screening, only opportunistic screening if the patient didn't have screening before or has a family history or has other risk factors. And then again, 17 to 21, it's repeat screening for the universal on every patient, because there is a concern that if the child get to puberty before the time in 9 to 11 years of age that is checked, the pubertal changes may mask the FH phenotype in the patients and we miss it. But by 17 to 21, we can make that diagnosis for them. So the guideline recommend that if your LDL at the first time with fasting lipid panel is more than 250, you refer the patient to the lipid specialist. If its numbers are between 130 and 150, we're going through diet and lifestyle modification, increasing vegetable intake and improving their saturated fat intake, and then rechecking it after 6 months, and then again, and if there is numbers remain above 190, then consider statin therapy. And if it's 160 and above plus risk factor, start therapy. And same methodology that adult they use with clustering of the risk factor and increasing risk. So why there is so much controversy is that twice USPSTF has this I recommendation saying that there is insufficient evidence to recommend or discourage this practice. So they don't say don't do it, but they're just saying that it's just insufficient. And in fact, our American Heart Association guideline in 2018, it says it's reasonable with class 2B because of the insufficient data that we had. Now, as I mentioned, we had a little bit more data since 2018. People, they contemplated that the reason that the compliance with the AAP recommendation is not as high as it should be, it's because of these weaknesses of the data, and perhaps that recommendation is not based on appropriate evidence, which, as I already presented some data, I believe that's not true, and I think that we have room to improve our rate of diagnosis of familial hypercholesterolemia, and the time to do that, it's going to be in childhood, because afterward it's hard to catch the patients. And there is a lot of other factors comes into play. I do not think that making a diagnosis at 20, it's going to be even possible. The child is going to be at that point, or an adult, young adult, is going to be at that point in college. The last thing they're thinking about is prevention and chronic problems that they have. There is a lot other on the plate of that young adult about their education and job and everything else. And are they insured? They're not insured. We're losing a big opportunity of making a diagnosis earlier, educate the patient about what they have during their adolescent year to improve their compliance. So I think it's not just a matter of is this actually improving outcome or not. It is more practical, at least in our system in United States. So what did USPSTF recommended? They mentioned that the potential benefit of screening is that we know that FH atherosclerosis changes start at the age of 8. We know that LDL more than 190 in an adult versus less than 130 has a hazard ratio of cardiovascular event of 4. We know that observational studies in adults suggest prognosis of FH improved since the advent of statin. We know that genetic diagnosis affect the risk stratification. And there are evidence that elevated lipid from 3 to 19 years of age are associated with fatal cardiovascular event 35 years later. There is the hazard ratio of that is 1.2, but it's statistically significant. Now, is there a harm in it? That's the question, that are we causing any harm? Now, the question on the treatment, we don't believe that there is harm, but we have only 20 years follow-up studies of the trials of statin in children. But the question of harm of causing anxiety and unnecessary testing and unnecessary stress for the families and children is a matter of debate, and we need more studies to show and look into that and say that should we do this not to cause harm by causing anxiety and stress for the families and children. Now, what they recommended as the gaps of the research that needs to be filled, as I mentioned, I don't think it's ethical to be done. One of the topics that they mention, it's comparative effectiveness data assessing the optimal age at which to start lipid-lowering intervention for maximal benefit in children and adolescents. So the recommendation is to do a drug trial and start at 8 and 10 versus starting at 20 and follow the children for another 20, 30 year. Although that it may be a very difficult study and very expensive to be done, the question is that, is this ethical with the current evidence that we have on the treatment of familial hypercholesterolemia to do such a thing? And that's open for discussion. Now, if we just focus on FH, I think it justifies screening for because we want to improve FH. But do we have any other problems? I think that we have a bigger problem in today's age with all the risk factors that we have. This is a small study. I looked at the population of one large hospital clinic in Brooklyn, and comparing that to the Cardia Start baseline study. Average age of our patient population was 17.8 versus Cardia study was 24. So we're talking about 6-year younger children. And it was predominantly African American versus Cardia was a balanced study that about 47% they were African American. But if you see that the non-HDL, as expected in the African American population, that they have better cholesterol level, it was much lower. But the blood pressure, despite of 6-year younger, it was higher. The diagnosis rate of hypertension was the same 6 years younger. Diabetes rate is 3 to twice higher comparing to the Cardia study. Now, I have to mention that the Cardia study started in 1980s, and we're talking about 2022 or to 2024 for this current population. Despite of the fact that the documentation of smoking was not done correctly, it's impossible that only 2.4% of adolescents they were smoking. We got to a P-Day score, which is a measurement of clustering of the risk factor equal to the Cardia study baseline data. I have to mention that other studies has shown that for every 1 point higher P-Day score, odds ratio of coronary artery calcification at the 40 to 45 years of age is 1.2. Now, starting this at 6-year younger, you have the same risk as 6-year older patients. It seems to be concerning to me that we're going toward having much bigger problem coming up toward us as an adult atherosclerotic disease, that the way to prevent it is come to pediatric and decrease these risk factors. If we wait by the time that they have established disease, it's already too late. I often make an talk with the children, and I tell them, you brush your teeth and or not, and they say yes. I say, so why do you brush your teeth? They say, because I don't want to have a tooth decay. I say that if you have a tooth decay and you brush it, it's not going to get better. Is that true? He says yes. I said, okay, so the same thing we're talking about your heart. We don't want to wait till you have your heart decay and vascular decay, and then you start to go and get treatment for it and trying to improve your outcome. We want to prevent it before you have an actual established disease. Now, as I mentioned, if we look at the cholesterol level in this population, I was just curious to know how many of our patients, they were satisfying criteria of being screened further and getting genetic testing or further evaluation for familial hypercholesterolemia, and it was only 1.1%. And I have to be proud to say that 92% of children in my program, they were screened. That it's much higher than the published data of at best 20%, 30% around the country, they have screening children. We got to 92%, and I'm hoping that we improve that even to get to the 100% of the children they get once screened. But are we good in detecting which one of these 43 patients in this 3,000 population they had actually a fetch? No, unfortunately, between all of them that they were referred for evaluation, only 6 showed up, and all 6 they were gene positive, unfortunately, or fortunately that we have a diagnosis. And in fact, we diagnosed a lot of their parents. Out of that 6, I think 4 of them, they were not known that they have to be on treatment, and diagnosis was not made before. But only 1 parents, they were treated before. And majority of the other children, they had an appropriate LDL cholesterol that we just needed to give them diet and lifestyle modification by their pediatrician, which addressing that, and they do not need to be referred or having further evaluation. So in summary, I would say it's a great opportunity to do universal screening in children to improve familial hypercholesterolemia, and I think we should continue to use that opportunity, hopefully to improve our detection rate in United States. I'm going to open for question and discussion, and I'll be happy to hear your thoughts on it, Rob.
Well, thank you so much for a wonderful talk, and please write your questions in the Q&A or chat section, and we'll look at those as we go. I think I'll start with a question. I mean, with your talk and with the curve you showed of the LDL years, you beautifully outlined how kind of bending the curve toward health earlier in life, or anywhere earlier in life, can really have a great ROI. And there's a pretty big gap between where we are and where we could be with more optimal lifestyles, which would, of course, be helpful across the lipid spectrum as well as other things. What tips would you have for us in terms of helping the individual patient achieve behavior change, adopting a healthier lifestyle on both an individual level and on a societal level?
I think it's our problem of prevention in general in United States has to be addressed both from the clinician side and the public health standpoint. We have a major education issue that it sounds like that now it turned into a culture that it's okay for a child not to ever have vegetables. It happens even in our own families that you take your child to a restaurant and there is a vegetable on the side of their plate, and they put it to the side, and parents, they eat it. It's okay. It's a child. He's not going to have the vegetable. And that comes as a result of this fact, this idea that it's okay for children not to have it, which is not a true statement. I think if we make those habits early enough, then you have a better chance to, in general, to improve vegetable intake, to improve lifestyle, to improve activity level. When we're looking at the life essential eight criteria of American Heart Association and the incidence of and the prevalence of optimal level in children, it's so low that I had a different talk with pediatricians that one of the pediatricians stand up and say, maybe you should change your standard. If you're only telling me that only 5% of children, they have all these eight optimal life cardiovascular risk factors, maybe you should change your measurement tape because I can't go after 95%. But that's why I say it needs a lot of education and a public health changes, that we get to a level that we get this norm to be changed, this idea that this is our culture or this is that it's okay not to do this has to be changed. And we do it in our offices, we keep talking about it, but I don't think it's going to be enough. We need bigger audiences to get through.
As adult cardiologists, we would have limited experience, treating younger patients, 10, 11, and teenage years with FH or heterozygous FH with a statin or possibly even other medications. How do you introduce the statin to teenagers and younger, and how do you monitor them over time?
So I think the problem in teenagers, it's more of a non-medical part of it, actually. The complications and side effects of statins are much less in children than in adults. In fact, in all the published data and non-published of our numbers with my colleagues, that we do few thousands of patients on Lipitor and other statins. I have to say less than 1% they complain of muscle problems. Which comparing to adults, which generally we think about 20% rate of muscle-related complaints. Why there is a difference, I don't know, but it's much lower. And same story with the liver enzymes elevations. If the doses are as small as 10 to 20 milligram, it's very rare to see it, except in the obese one that they already have non-alcoholic or metabolic fatty liver disease also, which is an additional problem that we have to deal with. So I think that starting it will be, from a medical standpoint, very easy and safe. And I start with 10 or 20, depending on how much goal I have of how high is the baseline LDL level is. And then generally speaking, I don't go up before add ezetimibe on the side of it. And then if needed, I may go up in the dose or add Repata and inclisiran and other medication. But from the non-medical standpoint, is a major issue. Kids, either they don't take this seriously because they never had any symptoms and they're very poorly compliant, or if you go full-fledged and explain the whole problem too intensely to them, or if they're unfortunate that their parents died as a result of this, they get depressed. We've had patients that they actually committed suicide during this process of diagnosis and treatment. It's a lot of other hand holding that as a pediatrician we get used to it. And I think that in adult world we do it less. In adult world, you write the prescription, you explain about the side effect of it, you say come back and check your labs again, let's see how things are going. We have to hold their hand way more, and for that reason I often bring them back for that first year of treatment at least 3-4 times back to my office to see how they're doing both emotionally and compliance-wise, because I'm afraid that they're not going to take their medication. And very often, even after a few years of being fully compliant and followed correctly, you'll see that in the middle of teenage years, the child decide that I don't want to do this anymore. I'm tired of it. I don't want to do it. And it takes hours and hours of back and forth sitting in the office and explain and show graphs and all of that. And as I mentioned, it's a big, difficult balance that should I tell him that how risky it is and you're actually being putting yourself at risk of early heart disease and make him scared, or which one I can talk like that to them, not to make them to be actually more oppositional to it. It's difficult. I would say that there is I I'm struggling with it. I don't know what to do with the compliance issue. We're spending a lot of time with having a coordinator of the program, contacting the patients frequently, following up with the parents, trying to make sure that the child is taking it, but still our compliance rate is not as good as what it should be.
In regard to the portfolio diet, which is in general a high fiber plant-based diet, you know, in randomized trials of adults, you can lower LDL ballpark 30% or so. In patients with heterozygous or homozygous FH, around what, and of course, eating that way is good for you for many, many reasons, not just for LDL, but what kind of percentage drop might we be able to expect in that population with a portfolio diet?
On the trials and studies, it's about 10%. But anecdotally, I have patients that we started with LDL up. In fact, the patient was in my office yesterday, and I said, everywhere I go around, I'll talk about you, because we started with LDL up to 20, and she came back with LDL of 120, which I even questioned the whole diagnosis at that point.
Yeah.
But we did gene testing, and the genes were positive. And since is varied, it goes up and down, but she has been able to keep it between 140s without any medication, 140s to 150s. And I have a difficult time to push her to take medication, because 140, 150, you're actually doing a good job as a young person. I'm not sure you need medication at this point. I said that perhaps when you get to adult life, you will need medicine, but at this point, I just say check it twice a year, make sure your diet is actually keeping the level at the same level. Anecdotally, I get these results, but in studies is only 10%. So I think that I will try it with every patient. I give them a whole handout and a lot of discussion about how to improve the increasing fibers and the implant stanols and decreasing saturated fat, and rechecking it in 2-3 months and see where I am. If I'm getting to right direction and I feel that there is more room to work on that, I delay the treatment. Even though that I believe that an FH patient perhaps almost always need medication, I have a luxury of time to wait another 6 months or a year to see that how I can establish a better lifestyle and make sure that that is a habit formed for the teenager or a child before I go on medication and make the child think that it's okay to eat whatever I want now that I'm medication.
Given that for with FH, with a given LDL level, let's say 130, for example, if you, I'm sorry, just with a given LDL level of 130, with FH compared to someone without FH, as you nicely pointed out in your graphs, there's ballpark double risk down the line, which seems like it's possible that there's a non-LDL component to that risk. But if you were to give that person with FH and the LDL of 130 a statin, would you see additional cardiovascular benefit above and beyond someone with the same LDL without FH they have incremental benefit given their increase in risk?
So I don't have a pediatric data on this. I'm quoting on adult data, which they believe that, yes, you had an improvement by doing that. But in pediatric, we don't have any data. It's not even surrogate outcome like carotid intima media thickness data on that level. All our trials are based on starting LDL of more than 160. And in fact, the new injection cholesterol therapies like inclisiran trials, where we were starting with the starting LDL of 140 on top of statin and ezetimibe and everything else. So we don't have data to say that at a lower number you actually get improvement in atherosclerosis at such a young age. I believe in long term we will have something because of the cumulative LDL burden, but I don't know if that's true. And I turn that back and asking you question. I know that in adults the LPA being high, still there is benefit of decreasing LDL by statins, despite of the concern of increasing LPA by about 20%. Do you think that 20% in such a long-standing thing for me as a pediatrician, starting at the age of 10, will end up to have some problem of associated with LPA by that 20%, or we should feel comfortable to just give statins and don't be worried about the LPA was high or not?
Yeah, I mean, it's a great question. I don't know the optimal answer. My guess would be, given the just reams of data about the benefit of lowering LDL in appropriate populations, which would of course encompass in hundreds and hundreds of thousands of people, which would encompass people with higher lipoprotein(a) levels. I would think that the benefit of the statin would outweigh the risk. And if there was a long-term follow-up of the 4S study, which is, of course, was a statin trial, and long-term, and I'm not aware that they ever published lipoprotein(a) data from that, but a larger study over 4,000 people. And even 10 years after the study ended, those who had received statin did better. And presumably some of those 4,000, given how common high lipoprotein(a) levels are, had that at baseline, and that they went up during the treatment period. So it's an extrapolation, but I would think that it's beneficial. Well, the devil, I guess, would be in the details. Like if your lipoprotein(a) level is 600 at baseline, maybe that a 20% bump might give you pause. But I think in general that you would expect the benefit to outweigh the risk, and hopefully, as you know better than I, this conversation will become moot within a few years as we have directed therapy for lipoprotein(a).
Hopefully, yeah. No, thank you. No, I do it, but I'm afraid of it. I don't know. Am I doing the right thing or not?
Well, I hear you. Hopefully in a few years we'll have more solid answers. And thank you so much for a wonderful and incredibly informative talk. And we really appreciate your time, and Montefiore misses you.
Thank you. Thank you. I miss everybody, all the friends in Monte also. Thank you. Thank you for having me.
Sure. Have a wonderful day.
Thank you.